Dr. Cucuzzella, I've heard him speak at Low Carb Boca, I believe, a couple of years ago. The main takeaway that I have was watching him on the stage. Is this one better? Yes. So there was a line that he said in that speech. Something about the hill that this is the hill that I will die on, or something like that. But it was basically, this is where I put my stand. And we all have to have that point in our life. This is where we're going to stand. This is where we're going to take a stand. This is where we're going to stake our claims. He's done something that I don't know that many providers can do. He went into a hospital and created a low-carb plan and implemented it into that hospital. I don't know if anybody else has ever done that.
No, very true.
And today he's tackling a topic that I think is going to be of great interest to you guys. It's of great interest to me because it is something that I hear talk about every day in my clinical practice. So, welcome to the stage.
See if we can go. Well, thank you, Amanda, Ken, and all of you for coming. This is my tribe, and the line was, this is the hill I will die on, and I'm now at the Veterans Hospital at Martinsburg, West Virginia. What am I doing here? This way. Whoops. Forward. Yay. Okay. Yeah, so I'm at the Veterans Hospital in Martinsburg, West Virginia. Left academic medicine about a year and a half ago, still involved with research at West Virginia University. But as a fellow vet, I think that's a population that really needs help, and we're doing it, right? Andy is here, a pharmacist at the VA, so I'm glad that Andy is here too with me. But Amy's question, I think, that before we start, so why do we overeat steak? So it's the hedonic drive of food. And what that is most of our joy comes with those first few bites. And so I love like chocolate ice cream, and I could go to the ice cream shop and get one the size of my head, or I can get like the kitty cup. But the joy comes from those first few bites. So you are what you think. So just remember that when you sit down to something to eat, that joy you get from it is not going to come from the piece the size of your head. It will come from that little bit. But just play with that next time that you might be thinking you might overeat. So we're all trying to figure this out, so none of us have the answers. So the once and future use of GLP-1s. So actually go back to my last trip to Nashville, and I think maybe this is relevant today. So in 2018, I was invited to Vanderbilt University to give endocrine grand rounds as a family doctor, which was highly unusual because that's the high academic specialist. And somehow a friend of mine, Dr. Catherine DeHeer, is on endocrine faculty there, and she heard about what we were doing in our hospital, which was taking carbohydrates off the menu for diabetes patients in the hospital. We had 10-gram carb per meal. We got rid of sliding scale. They had extra meat, extra salad. You couldn't even finish it all. I mean, it kind of makes common sense, right? So she invited me to give grand rounds at Vanderbilt, and they toured me around all the basic science researchers. It's kind of like a day when you get invited to give grand rounds at an academic hospital, and part of that is they're kind of like showcasing what they do in case there might be a position for you there. But I remember going into the office of one of the basic science bench researchers, and he was studying GLP-1 peptides, and he was talking about all the crazy different things these peptides were doing. This was 2018, right? So I think what we were talking about then is what we're going to talk about today. Now, I'll hang out at lunch for questions because this will be like 1.25 speed if you listen to podcasts. There's a lot in here, and you're going to get these slides. There's a lot in here. This is a big topic to try to do in 50 minutes. I won't even touch it, but maybe if you leave here thinking a little more and not making just assumptions about things, then we've accomplished something, right? We are what we think. Okay, disclosures, I own a little shoe store selling these minimal shoes. I wrote a book. I'm board member of Society of Metabolic Health Practitioners, which is a group trying to develop metabolic health as a subspecialty. I'm a founding member of the Nutrition Coalition with Nina Teicholz. I'm on the science advisory for allulose, RX sugar. You got one of those little bars used for a lot of type 1 patients now, as well as the CGMs, Abbott. So objectives here, we're going to tie this GLP-1 use into what are called the 4 pillars of medical ethics. Why does this matter when we're talking about these drugs? What is the crisis? What is this peptide? What are the benefits? What are the harms? What are the health equity issues? Then what can we do to help our patients? This is about, getting better, right? So the theme of this conference will come kind of to closure at the end of this talk, because a lot of people still need help. Never give up, right? So never give up. So what are these 4 pillars of medical ethics? These are out there to protect patients from abuse, but they also give us the moral framework, provided that we as physicians have some kind of moral framework. The first one is called autonomy. That's shared decision-making, right of refusal, informed consent. It involves a competent patient, full disclosure of the treatment, the risk and benefit, and a voluntary consent. Some of this seems self-evident, but this has to happen in the office. Beneficence, what I do to you should do good for you. Okay, there is no kind of taking one for the team in healthcare. Non-malfeasance, most of us have heard of the term do no harm. This comes from Hippocrates in his work Epidemics. As to disease, make a habit of 2 things. To help and at least do no harm. So the risk-benefit of a treatment should be favorable to you as that individual. And then there's justice, and this is where things all get blown up with the GLP-1s. So you have to have fair and equitable distribution of a treatment if it can help people. This should not be reserved for those people in Hollywood, right? That's maybe a little bit of, the media stuff, but no, I mean, who is acquiring these meds now? If you have a credit card, you can get these meds. But there's also another part of justice. So the burden of healthcare should not fall on people who don't have privilege, meaning we shouldn't be doing experimentation on certain groups that are not privileged groups. And certain groups should not be subjected to restrictions where other groups might have privileges. So maybe, and this is not about pro or anti-vax, but I think a lot of our pillars of medical ethics got thrown out the door during the pandemic, when Dr. Fauci said this, and this was exposed in the Senate Select Subcommittee on the coronavirus. When you make it difficult for people in their lives, they lose their ideological bullshit and they get vaccinated. Okay, so just pause on that. So that medical ethics did not happen in that sentence. Okay, but that's all about that. All right. Whew. Johnny Manjaro. Slick. Everyone, Manjaro for all. All right, everyone should be on Manjaro. We have a lot of fanboys, fangirls for Manjaro. And then there's the Keto Harder group. All right, come on, just keto harder. Okay, this isn't an either or, so maybe we should be looking at a both and when we're talking about these things, as long as we understand them. Okay, so first pillar, autonomy. The first thing we need to know if we're a patient is, what is the harm of obesity? Right? What is the harm of obesity? So later on, you guys are going to get this slides. I want you to watch this 9-minute video from Charleston, West Virginia, which is now one of the most obese cities in the country. And you're like watching, they're just panning around. Like, where did all the obese people go? That was 40 years ago, but it blows. I mean, pull up a picture of the beach in some town in 1960 or 70 or 80, and it's like, whoa, okay, that's real. Obesity is a global disease. You see where obesity is happening, mostly Western countries, a lot of Middle East, because they've adopted our lifestyle, and a lot of the countries of wealth in the Middle East, Australia, New Zealand, Canada. You see Central Africa, Asia. There's, that land that does not need Ozempic. Obesity in adults. So obesity affects your health. This was just published a few weeks ago, and I just red-lighted there. I mean, that's the short list. Yes, obesity, high blood pressure, heart disease, diabetes, early death. I mean, you name the organ system. This article also had a nice little graphic. You name the health problem that you don't want to get, and obesity increases your odds. So obesity is a disease. I like this editorial, which was in the BMJ. Preventing obesity is different from curing it. There's this health at any size movement now, and I certainly believe and practice that we should not be, giving any stigma or blame to people with obesity, but we have to be realistic that the health and economic damage of obesity is far beyond anything that our economy and healthcare system can sustain. If you're obese, you have 7 times risk of type 2 diabetes. I mean, that right there should terrify you. Fat is not inert. Pro-inflammatory state, both from the inactivity and the body fat. So many comorbidities. We call them comorbidities, right? These comorbidities. 75 years ago when they started the veterans hospitals, chronic disease did not exist. There was not a term called comorbidity. There was no chronic disease. Now everyone has comorbidities. So pause and think about this too and how we're framing obesity in some of the narrative. Imagine if we treated anorexia like this. Oh, this is just health at any size. We shouldn't help you, and that's a cosmetic problem. I mean, you look at me like I had 2 heads. But that's how I think a lot of obesity is viewed out there. This is just a cosmetic problem. Oh, it's not real disease. You don't need this. No, it's real. It's real disease. So autonomy, first thing, if you're going to talk about these meds, you got to know what they are. What is a GLP-1 peptide? So enter the Gila monster. Who's heard of the Gila monster? Is it called Gila monster? Yeah, so the Gila monster venom is similar in structure to GLP-1. And the first medication that was made from this Gila monster venom was, it's Exendin 4 is their venom. It was called exenatide, and it was called Byetta, shot twice a day for diabetes for what is called the incretin effect. So Exendin 4 from lizard to the laboratory and beyond. So this lizard venom is 50-ish% like native GLP-1 that our guts and our brain makes, but it has a much longer life. It doesn't get broken down. So our own GLP-1 gets broken down by DPP-4, which is another peptide. So just type in Daniel Drucker. If you want to learn the history of GLP-1s, Daniel Drucker's the guy. He's up in Canada. I think he's published like 100 papers. He is the founder of this. So what is GLP-1? So GLP-1 is made from the luminal L cells of the distal end part of the small intestine. And it's also made in parts of our brain too. Then there's what's called GIP. So tirzepatide also has another peptide called GIP, which is made higher up in the K cells. But that just tells you, where are these things when you hear it. So over there to the far side of the slide is native GLP-1. But these medications have different kind of protein or peptide attachments, so it doesn't get broken down. So it stays in your system a long time. And that's just the molecule of semaglutide and tirzepatide, which would be Ozempic and Mounjaro. Incretin effect. So when we eat glucose, or drink glucose, it's different than putting it in our IV. So our guts actually have an enhanced insulin response, a decreased glucagon response when we eat food compared to just putting it in our vein. And that's been called the incretin response. And that's part of what these medications do. When you hear these medicines make you put out a little bit more insulin, it's enhancing that beta cell insulin production. That's why it is effective in diabetic. But on the counter to that, people tend to eat less because you're all thinking, wait, more insulin, no good. But if you're eating this much instead of this much, the net effect is going to favor less total area under the curve of insulin. So that's incretin. Now, if you want to read all of these trials, this article would take you a night to go through. It's a 37-page database of every trial. And it's, okay, so you don't have to read that, but it's a lot if you would like nerding out on this. Okay, so second pillar, beneficence. What are these pleiotropic effects? What that means is multitude of organ and cellular system effects. It's not just affecting one system. How did we use these meds before obesity? So we used these meds for 15 years before they were approved for obesity. Christina Van Hilst and I worked in a clinic. We had sample refrigerators with Ozempic. Like, no kidding. Like now that would be like 50 grand. I mean, they were just stacked up, right? And we would use low doses because it would help people on big doses of insulin be able to get control of their appetite, come off of big doses of insulin. We didn't really know why it worked, but it seemed to work when you actually taught them the terrain of how to eat and live and get rid of their stress. But the stuff worked. We never cranked the dose up. So this is an article we published in 2021, adapting medications to type 2 diabetes on a low-carb diet. Green light, right? This GLP-1, green light. This was like, oh gosh, you can get a hold of this. Shit's gold. It's good, if you can get a hold of it, right? So, okay, now what changed the world? Where did we all go sideways? So this was the step 1 trial. This was the obesity trial. This was tremendous weight loss. Not quite to bariatric surgery, and you couldn't deny that. You look at that slide, whoa, it's like 15% weight loss. And like the majority of these people, 5%, 10%, 15% weight loss. So this was real weight loss. This wasn't noise, this was real signal. And then comes tirzepatide, 25% weight loss. Okay, well we need to look, no, we have to understand that. What is going on? Who is this for? Because you see the placebo group there, they're all getting coaching, right? So these people all get intensive coaching. It's not like they're just on the internet now, like getting it. So these people are in clinical trials, selected, no exclusion, getting coaching. But no, they're like coaching, right? The placebo group loses some weight. 4.8% isn't piddly, but it's not 25%. Now this is coming to a theater near you, retatrutide. It's called the triple agonist. So it enhances GLP, GIP, and glucagon, which will suppress your glucose production. So like this one's coming. This is phase 2 trial published in New England Journal last year. So we all know that these medications by category, if you could, in essence, make them as cost-effective as metformin, or it's better than insulin for type 2 diabetes. Would anyone disagree that giving more and more insulin for type 2 diabetes usually doesn't end well? Yes. So we know it is better. And here's just, if you have to have a clinical trial on this, you give glargine, long-acting insulin, versus tirzepatide. There's 2 graphs there. One is the weight loss. You're like, oh, wow, there's some significant weight loss there, and weight gain on the insulin. But look at the A1C reduction. These people became non-diabetic. The glargine, right, the more insulin you give, the more resistance you give, and you see that curve. The glargine, they're getting worse at the end of the trial. Better than glargine. Tirzepatide versus semaglutide. So tirzepatide is more potent for weight loss than semaglutide, at least what we know now, if you're using it for weight loss. But when these studies are all funded by pharma, designed by pharma, run by pharma, everyone has conflicts of interest. So they're not necessarily like comparing apples to apples. So they're cranking up tirzepatide to max dose in these trials, keeping the semaglutide at 1. But they both work, but probably from what I understand and seen with patients, tirzepatide probably a little more potent effect. This was a 2018 article. People were already talking about all of these other effects of GLP-1 peptide at a cellular level for different organ systems. This one published just 2022. This was really good. It's about 10 pages, and it goes through everything involved in cellular aging. That's probably the biggest disease all of us have. Anyone not getting older here? Yes. Aging is a disease, right, at a cellular level. So it went through like every organ system and what GLP-1 peptides were doing to, it's probably going to be like, I'm sure it is now, in all these anti-aging clinics now, they're giving like low doses of these peptides. So this Forbes article I thought was really good because they had links to the studies on these meds to basically every chronic disease we talk about in low-carb conferences, that it had a positive effect on these things. Cardiovascular benefit, I think everyone's heard that. But there's a lot of shenanigans when it comes to reporting clinical trials. 20% benefit, right? You're like, wow, that sounds really good. But that's called the relative risk reduction. Okay, but what we want is the absolute risk reduction. So it took an 8% cardiovascular risk down to 6.5%. So that's only, in essence, a 1.5% risk reduction, but they take that they do some fuzzy math and make a percentage of relative risk reduction. So you have to kind of read the fine line in these trials. So it's not 20%, it's about 1.5%. And of course, there were more adverse effects in the medication group. 16% had adverse effects versus 8.2% placebo. So that's an absolute risk reduction of 8%, but a relative risk reduction of 50%, 8 to 16. It kind of halves it if you take the med away. This was a meta-analysis on cardiovascular data. What was interesting is you hear a lot, well, it's just because of the weight loss the heart effects were better. But actually, if you control for all the factors, the weight loss, the A1C loss, there is still a signal that the peptides probably do have some unique cardiovascular protection. But again, maybe 1.5%. It's not going to cure cardiovascular disease. Beta cell function, this is fascinating, right? So restoration of beta cell function is really the holy grail of type 1 and really type 2 at ender stages. So there is, this one, 2017, beta cell function. So, back in one of the earlier slides, if you want to kind of figure out just what do I want to learn, just type in GLP-1 peptide and whatever it is you want to figure out or study and Scholar or and PubMed, and your computer lights up with all of these studies. So I'm just picking out a few just as an example. You could be on the computer a whole week. PCOS, not surprisingly, it helps PCOS. That's insulin resistance. This was an early liraglutide study in 2017. Dementia, Chris Palmer is back there, right? So these GLP-1 peptides, neuroinflammation, right? So Amy Berger, right? So you've got some of the top Alzheimer's and psychiatry researchers in the country right here. So yeah, this is really curious because we have no drug treatment for dementia, right? We really have no drug treatment that's efficacious for dementia. So neurodegeneration, neuroprotection. So this recent article, this one was 2024, July, goes into a lot of the mechanisms of that if you're curious. But, again, it's expensive therapy, but, dementia, Parkinson's, you talk about any type of neurodegenerative disease. The FLOW trial, I love the name of the trial, the FLOW trial, kidney trial. This one was stopped early for a unique benefit to the kidney. Diabetes patients have a lot of kidney disease. Not too surprising, NAFLD, which is now called MAFLD, which is metabolically associated fatty liver disease. Now, this article from 2014 was making the case that people with NAFLD had GLP-1 deficiency. No wonder why maybe they respond to the peptide. They may actually be deficient, right? So they could keto harder, and if their brain is not telling them, to shut off the food, then maybe they need help, right? That's the theme of the conference, right? Microbiome. If you have a distorted, this is in rats, but maybe it's relevant to humans. Someone's got to study it. So dysfunctional microbiome creates GLP-1 deficiency. So a lot of these folks are in the well. They need help. Osteoarthritis, liraglutide study, this one was just published this year, has anti-inflammatory effects on the chondrocytes. So Lloyd back there, bone on bone, he was saying, lost 100 pounds eating low-carb keto, less inflammation. So we all know that inflammation is real. You name the addiction, GLP-1 and whatever addiction you want to study, and then PubMed or whatever. Whoa, addiction is, I think, going to be a big part of the use of these peptides. Just this one is nicotine, right? But we're talking about way more serious addictions too, and possibly using this, but again, with the right support system. All the addictions we deal with in Appalachia, Tennessee, Kentucky, West Virginia. Maybe some of this has to do with the shrinking fat cell, because we know that when these fat cells get large and inflamed, so on the far side, the big adipocytes are South Asians, and the smaller ones are Caucasians. Because the South Asians, they call them the skinny fat, right? With a BMI of 26, they have all of those metabolic diabetic complications because there's a lot of inflammation, ceramides, interleukins, all these disruptive reactive oxidative species come from this overinflamed adipocyte. So if you can shrink that adipocyte, even outside of pure weight loss, it's going to have benefit. So non-malfeasance, right? What are the potential harms? So here's your other kind of search engine thing, in this world of social media insanity. type in GLP-1 agonist and whatever you're terrified of, and Scholar, and there'll be a social media article about how horrible this shit is, okay? Can we say that? Because I like, being military, right? But I think everyone's heard this saying, there are known knowns, these are things we know, there are known unknowns. That is to say, there are things we know we don't know, but then there are also unknown unknowns. There are things we don't know. Is that true about these meds or any med? Yes. Can we have an amen for that, right? We're in the Bible now. Okay, and another amen. 2 truths about medicine. Either it doesn't work or there are side effects. Okay? All right. Yeah, I like that. Look, we're doing a revival here. It's not my style. I grew up Catholic. Yeah, straightened my sorry ass out when I got thrown out of public school. But that's another story. All right. Ozempic face and Ozempic butt. All right, next. We're not talking about thyroid cancer risk. So this is a black box warning for the meds. This was in rats. That's a black box warning. Okay, so is there reality to this? Maybe so, right? So the French database, this was mostly liraglutide. Yes, when they just kind of gathered the data of all these people on the meds, there was a slightly higher thyroid cancer risk. But then again, this one just got published, was 2024, January. No associated risk. You're like, well, WTF, right? So, but take it, back to common sense. If you have a family history or personal history of medullary thyroid cancer, do not take, or make sure the risk benefit. If you were BMI of 50 and already whatever, what did you call it, the super obese? Super obese. And no one in your family has ever had thyroid cancer, I would probably say, I'm in. All right, so what's going to take you out? All right, so risk to your pancreas. When the lawyers are getting involved, it's real, right? So this is real, so the lawyers are involved. Yeah, people are cranking the dose up. Yes, there is an increased risk of pancreatitis, in this review, but the doses are not controlled for. But again, what is your baseline risk? People who have obesity have very inflamed pancreases to begin with. But then like another review, 34,000 patients, like everything is like goes back and forth. So where the experts disagree, the ignorant are free to choose, right? That'd be you, me, whatever. But no increased risk. So I'm just throwing you both sides here, that there's unknown unknowns, or whatever you want to say, known unknowns. I think it's known unknowns. We know there's a lot of unknowns. And then there's a lot of unknown unknowns. Gut paralysis, right? Everyone has heard that, right? Gut paralysis. This will freeze your gut. Gut paralysis. I like this study, pharmacovigilance. Every time I put a talk together, there's a new word. So this was like this robust database of all of the side effects, GI, for these medicines, and this was like a 30-page article. But some things came out of this. Serious stuff was pretty rare. So if you get this gut paralysis, stop the medication, and it gets better. Right, so most of the side effects happen early and then go away. And the side effects happen to older and sicker people because they're older and sicker at baseline. So not a lot new under the sun there. But again, every medicine has a side effect. There's no inert substance in pharmacology. This was the STEP trial. People with severe obesity have a lot of GI side effects every day of their life. Fair to say if any of y'all have had severe obesity or still do? Yes, so there is a little more than the baseline nausea, dysfunctional dysbiosis, all these different side effects, right? Gastric emptying, y'all maybe saw that one. It was the anesthesia risk. Like if you're on this, you shouldn't go get anesthesia because you're going to aspirate. So it's about a 36-minute, so in reality it's about a 36-minute delay in gastric emptying if you were on this. So if you're going to get surgery, so just think about that. But it was really, liquid emptying wasn't affected at all. So I think this just made nice new clickbait. I don't think it's a big issue, but if it's you and you're having surgery, talk to your doctor. Right? That's what they say. Oh, this is the one. Okay, everyone has heard about this. If you're going to take this, you're going to waste your muscle mass. Everyone heard that one? Okay, so any form of extreme weight loss, you will lose muscle mass. Let's just kind of put it there. All right, so and then now pharma is trying to develop a drug for that. So, Jesus Christ. All right, so where did all this come from? There was a subset of 140 patients in the STEP trial. They used DEXA, and the lean mass lost approximately 39%. I don't like that. Doesn't sound good to me. I don't want anyone here losing muscle mass. Right? Sustain 8, this trial was using canagliflozin and also a GLP-1. And in both groups, whether it was GLP-1 or canagliflozin, which is another diabetes med, they all lost similar proportion of lean body mass, okay? But then I pulled up this systemic review, which I liked, because this is where common sense kind of comes in. So if you start this med and you lose weight, your lean mass goes anywhere from 0% to 40%, okay? It could be 0%. So how do we keep our muscle mass? Eat what? Protein, and do what? Lift some stuff. We don't want sarcopenic obesity. I'm worried giving this to frail elderly because they're overweight. No, that's disaster pants right there. So if you already are low in muscle mass and you're already kind of frail and you lose, so some people in this room look like strength trainers. They've got some margin of muscle mass to lose. Others have no margin. They're one slip, fall away from frailty and care homes. Everyone heard this one too. You're going to be malnourished if you take this. If given to the wrong patient, absolutely. So we do not want to be triggering, encouraging eating disorders. You need a good clinician if you're going to get this medication to make sure, no, you don't have an eating disorder, right? Self-acceptance versus self-starvation. We do not want people. We want people to love and accept themselves, not starve themselves. And if these meds are given to the wrong person, I've even heard some kind of things about them now. So even in Olympic sport, for example, so say you're a gymnast, right? So say you're a figure skater, your performance actually depends on how lean your kind of strength to weight ratio. And that dancers, ballet dancers, people in those kind of aesthetic sports are already bordering in that world. And if somehow now this is getting into the performance-enhancing drug world, because they're not drug testing for this in the IOC as they would be testing for testosterone, human growth hormone, erythropoietin, and other drugs of performance. So again, just caution in that group. Weight gain after stopping GLP-1, right? So yeah, what's going to happen? Yes, so here's one thing we do know. Weight loss with everything you and I are doing is difficult. Right? It's difficult, right? Never give up. So you pick whatever type of diet you want to do. The weight loss is quick, it'll plateau, and people tend to start gaining weight again, right? It's hard, right? So Ozempic or Wegovy, will it last? So this is probably the big trial, an image that gets shared. So the step 1 trial extension. So they followed a group of these patients out. Whoa, stop the med. A1C comes, that's like, whoa, resurfacing pretty quick. I don't have a comment on that, but that's real. So for many people, these may be lifelong medications. So just throwing that out. This is the extended select trial. So this one went out about 4 years. Only 1 out of 4 people stayed on the med. But yeah, so the long term, if you stay on this high dose and you haven't dropped out, because the majority dropped out for whatever reason, I don't know, but they dropped out. You can, it's deceiving because so many people dropped out. Of the people who stayed in the game, who could tolerate it, afford it, whatever, they kept some of the weight off, right? But this blows my mind. So this is from that same paper. And at the end of the paper, there's a conflict of interest statement. Yeah, it's crazy. There's 7 or 8 authors. So if you did the math, there's about 200 conflicts of interest divided by 8 authors. So if there's a young teenager here, they could tell me what that is per author. Terrifying. So really it is kind of like this analogy, I think, for a lot of people who truly, have medical grade obesity, right? We know this set point thing is like real, especially people who have suffered from obesity as like youngsters, teenagers. You're kind of pushing that underwater with whatever it is. It could be Mounjaro, could be ketoing harder, and then you tend to come up. All right, so enough of that. Drug shortage and compounding. So who in this room has heard that compounding is the most evil thing, most dangerous thing you could ever do? It's not. When there's a drug shortage, the FDA actually encourages proper compounding. These drugs are under shortage. 503B pharmacies, look them up. You can get proper compounded dose of this medication. There's a drug shortage. It's in the FDA right now. But again, you as a consumer have to be wise. Have to be wise. You don't just go on the internet and pick out something, right? 503B, I'm just throwing that out. So you could ask your pharmacy if you're getting it compounded, and that's a regulated compounding pharmacy. And maybe like at lunch, if there's any pharmacist in the room here, they could kind of like talk a little more about that. Because again, like safety. Of course, people now, they get it, if I got a vial, well, let me just give myself a lot, and they get nauseated, and then you throw the baby out with the bathwater. Compounded semaglutide overdoses. Do not overdose on this. Hello, don't overdose on this. We don't want you to small doses have that effect. Good news for addiction, bad news for depression, maybe. Okay, so this morning I went out for a jog, and I like to go out for a jog. It makes me happy, right? So if this medication is blunting that joy response, maybe this morning I would have woken up and said, F that, I'm gonna go to the bar or something. No, but that's kind of one of the counter arguments, right? So does it block how many of y'all in this room like to do something? All right, good. Whatever, so. 12-month neurologic and psychiatric outcomes of semaglutide not associated with a higher 12-month risk of adverse effects. July 2024. Now, one article is not proof. I don't know these authors, but again, you have to vet it, right? Your risk-benefit, back to the pillars of medical ethics. Resting heart rate, this is real. So it's even in the package insert. I don't know what that means, but to me, I don't want to have a higher resting heart rate. But I don't know what that means. I don't know the physiology. I mean, this is something unknown unknowns, right? Does that mean something? I don't know. This was a few weeks ago. Eye effects, right? Semaglutide is going to crush your eyes. This report here, 370,000 patients. No real signal to that. But don't rapidly drop your blood sugar, okay? That can affect your vessels, all right? Discontinuation, this is real, right? No, I'm flying through stuff. So Ezekiel Emanuel, very thoughtful writer. So 96,000 patients, 65% of the obesity patients had stopped it in a year, 45% of the type 2s. Many reasons for that, but just realize there is a high real-world discontinuation rate. In the UK, where the drug's cheaper, it's also about 50% discontinuation rate. Why do people stop it? I think kind of like everyone in the room kind of knows, right? My insurance dropped it, I got nausea, it just didn't work for me. I mean, there's a lot of reasons people stop it. It's all in those articles. It's like a long list, but people stop it. And we have to remember, who is this medicine for? Who was it studied for? This was not people who wanted to lose 10 pounds to fit into their skinny jeans. These were obese patients, medically obese patients. It was used for medically obese patients, not for people who just wanted to lose some weight. 230 pounds was the average weight in these trials. These people were not wanting to just lose a little bit of weight. They had medical obesity. Okay. How many of y'all remember this movie? What we have here is a total lack of respect for the law. Buford T. Justice. Smokey and the Bandit. In a world of short supply, who can benefit the most? Back to Ezekiel Emanuel, fair allocation. I'm just giving you some homework to read. Science should save all, not just some, right? Distributive justice. Who is getting these now? 2023, 40% were given to people who don't meet any indication. Who's doing that? They have to be getting that from a healthcare provider. That makes me sad. We all took it. When we took our, Chris back there, people graduated med school, we stand there and get our diplomas. We had to do that Hippocratic Oath thing. I forgot what it was, but well, we did it, didn't we? Shifting trends. Who's using this now? Shouldn't be too surprising. More of it is being used for obesity, being used disproportionately by females, whites, and people with obesity. Okay, so it's diabetes patients going down, obesity patients going up, coverage going down, right? So I'm trying to get this covered every now and then for patients, and you got to game the system. Well, they don't like to use it for obesity, so I need to convince them of all the other comorbidities. Maybe they'll cover it, because obesity is just cosmetic. It's a weight loss drug. But no, this is disease. But then we probably do have to prioritize. I was chatting with Andy at the VA. So how do you prioritize the limited supply of this? Who gets it, right? So there's a lot to that. So Denmark's GDP, I think, is 20% of Novo Nordisk is like Denmark's GDP. It's insane, right? So we're basically funding their whole national healthcare system, which they have a wonderful national, and it's the happiest country in the world too. I think they do that survey. So they're getting happy, fat and happy because of us. They're making money off of us, because in Europe, you'll pay under $100 for this. In America, it's $1,000. Justice, I don't know politically how that happens. How does that happen? And Bernie Sanders, people in the room may not like him, but he presented to the the Senate Health Committee the data of these medications. $1 trillion for prescription drugs. If we covered these drugs from $1 trillion, 3.1 trillion is like our GDP in this country. It's insane. You see all the cost comparisons of countries, and if we covered half of the people who kind of meet criteria, it'd be $400 billion, which is more than the total drug care spending in 2022. So the reality is, we can't afford the cost of this medication. So Medicare is tightening the screws. Medicaid is tightening the screws on this. It would bankrupt Medicare, completely bankrupt Medicare. Medicaid, now who's not going to get it? The poor, underprivileged are not going to get this, because Medicaid they can't afford to cover it. It's the reality. This was in the New York Times, my state of West Virginia. Public employers insurance, like public school teachers, now they're dropping this med. They couldn't afford it. CVD, in the ethics world. So we have low cost effective meds for CVD, but yes, there is some benefit to this for CVD, but again, it costs $1,000 a month. So what's the trade-off? So we're just talking about those things. We're going to fly through pediatrics because this kind of terrifies me. Is this a pediatric drug? So this graph is just one healthcare plan about these drugs being used in 12 to 17-year-olds. 2018, there was barely saw it. Now there's thousands of them being done. This was in the New York Times. If this lady, Virginia Soul Smith, lives in your neighborhood, you better look out for your kids, because she says this: what happens when your kid goes on a play date to my house, I can tell you, your kid eats 9 Oreos, gets them hooked. All right, I vehemently disagree with her. I'm a parent. I don't like that parenting style if my kid visited her house and if my family had obesity. So we can tell her to take her opinion and do something with it. So we're in this is a friendly room? Okay. All right. 6-year-olds. This is the dystopian future, right? Back up. Yeah, you're like, 6-year-olds. Because for kids, this probably will be a lifelong med. How did this get approved? There was one trial, 200 kids. One trial, 200 kids. It got approved. Who were these kids? They were very obese. It was a short trial. And look at that upper graph. Look when they stopped the drug. Oh man, they start gaining the weight. And the second one down there, this one here, look, wait, some of the kids gained weight on the drug. So again, unknown unknowns. We don't know what's going to, so severe obese kids, I think there's a role for this. But this is not the solution for obesity in kids. Look, it's just crazy. These scripts are now being given out by the thousands and thousands and thousands in kids. I like Robert Lustig. He talked about this. I'm concerned that doctors are going to rush to judgment and employ a medication that is very expensive, has its own side effect, without giving proper consideration to what the cause is. So we are at the world now of what's called Pottinger's cats. So has anyone heard of Pottinger's cats? It was a book written by a veterinarian in the 1930s, fed a cat its non-native diet, cooked the meat and gave pasteurized milk. 2 generations, they were not able to reproduce. How many generations do you think it took to restore normal, I know it's on the slide, normal fertility? 4. So you walk around Walmart now, and I think we're 2 generations into Pottinger's cats. So I know, it's like, whoa, the sky is falling. This S is real, right? So we are there right now. We are there right now in America. Watch South Park. It's actually, I think it's real. They're just making fun of all this in a way that's like real. Oh, God. Yeah, because obesity is a biopsychosocial problem, whatever that all means, right? Biology, psychology, social support. There is a lot to it, right? We need to kick this prescription drug habit in America. If the fish are dying, do you medicate the fish or do you change the water? You change the water. These are kind of some ways out. Where have we gone wrong with this med? Cranking the dose, right? We know that in any, so they've got more caffeine back there. So the more I have coffee, the more I would have alcohol. What happens to my tolerance? It's higher, right? Well, let's crank some more. Let's crank some more. This is not the ticket to success. We need to remain susceptible and be able to kind of see the peptide for what it is if we're using it with the right terrain support. So that's my opinion from observation, but also looking scientifically how it works. For obesity was the first time we cranked the dose. We used it for 15 years for diabetes. Never saw nausea, never saw, all this stuff because we never cranked the dose. Wouldn't even think about cranking the dose, right? Losing muscle, eat protein strength training. So there's some cost hacks. So you could take a semaglutide pen and use a click method, right? So you can use a smaller dose with the pen that's designed for big dose, same cost. Eating the same old shit, but less is not going to work for you. Eat nutrient-dense, low carbs. If you're a prescriber or a patient and you're getting this and you don't meet indication for it, stop it. Should this be a controlled substance, right? So I can't write opiates without, the DEA. So should this be controlled? Do we need to regulate it? Maybe we do, right? So it's rogue out there right now. It is rogue. So prime the patient, restore metabolic health. Nature's GLP-1. Our guts make GLP-1, but a lot of people, they're deficient in it. They've got all kinds of issues that their brain's not seeing their GLP-1. But we can restore protein and non-starchy vegetables, helps our gut make GLP-1, right? This is the proper human diet, right? Do the proper human diet. You'll upregulate your GLP-1. Do you need help? Maybe, maybe not. These are charts for the click doses. You're going to get all these slides, so you're like, oh, wow, I can click dose this. Meaning like just take, it doesn't say the dose because they want you to use the full dose, but it's like cutting pills. How many of y'all have cut pills? Yeah, save money, right? Just cut the pill. You got to know what to do. Cut the pill. Allulose, RX sugar was one of the little goodie bags. So there's some brilliant scientists now studying allulose for GLP-1 effects. So I'm like a bug on the wall in this group. So you've got like Jeff Volek, Ben Bickman, Rick Johnson, Dom D'Agostino. You name, these are like the rock stars of, like Nick Norwitz is in there. He's like crazy, brilliant. I don't think I've said a word at a single conference other than sharing some stories of my patients who are using these. But there's like real stuff going on. And it's pretty cool. Like the owner of this company really wants to help reverse metabolic disease, right? So like you wouldn't get all these people doing research, funding research if you didn't care. I think everyone in the room probably knows about 8 to 10 of those names up there. All right, this is worthy of a read. Time Magazine, The Land That Doesn't Need Ozempic. Japan. Japan enacted a metabol law. 4% of Japanese have obesity. The land that doesn't need it. The metabol law. If you're an employer, you're an employee, you better, they had like in 2008, they had like a point something percent uptick in obesity in some population data, right? And they sounded the alarm. Whoa, obesity crisis, metabol law, Gestapo, you lose weight or you can't go to work here, we're going to tax you. How would that go in America? Fuck off, right? Hands off. Yeah, F off. Don't tread on me. I'm not saying we should do that, but it's fascinating, right? So we did a study on CGMs. So in 3 months, A1C down almost 2 points, BMI down 2 points, 2/3. So maybe give everybody CGMs. These are just ways out. Depression was, when we did this, actually Chris is here, depression was the biggest mover. And when we surveyed these patients pre and post, their depression like went away, like in a way that was like crazy. So that's like another thing, right? Low carb for kids. We published this article a few months ago. It's a 10,000 word article that you'll have access to also, that goes into like the origin story of why we are obese and some ways out. Prader-Willi syndrome. This was one of the more fascinating studies that we cited in that article. So Prader-Willi is a genetic condition. These kids cannot stop eating. Like they cannot stop eating. The parents lock the fridge. So they are very small pilots. They put these kids on low-carb keto diets. They stop eating. Prader-Willi kids stop eating. Crazy, right? And they actually measured, this one was done in 2021, they were measuring GLP-1 and GIP concentrations in these kids, and they were upregulated by the low-carb diet. So the low-carb diet in that group, severely metabolically broken group, got upregulated and they stopped eating. Semaglutide versus Virta Health. So we have Chrissy and Angel back there work for Virta Health. Yeah, so Virta Health trials look pretty damn good, look pretty similar to semaglutide in A1C reduction, weight loss. You know, is it sustainable? You know, semaglutide sustainable? It's kind of apples and apples. If you look at the slide there, the Mediterranean diet really didn't work for obesity and diabetes remission. So they compared it against Predimed, really minimal to no A1C reduction, weight loss with the Mediterranean diet, but Virta Health and semaglutide like 15%, you know, so interesting. I'm going to finish here with just a few random case studies and I'll stop, and I'll hang out at lunch for questions just so we can get to Amy, because I know there's probably people have some questions. So a few veteran case studies. So I'm in the real world trying to help people in a world that really does not have access to these drugs. So these two people are fascinating. I saw them both within the last couple weeks. You know, the top one there, he's 424 pounds, saw me in March. He was stuck, didn't have access to GLP-1, and he said, what about compounding? I said, yeah, you know, go try to, you know, he had the means to do it. He found a compounding pharmacy. He's eating high protein, low carbs, going to the gym 3 times a week now, doing jiu-jitsu. He feels like $1 million. Look, he's almost lost 100 pounds. I don't think without GLP-1 he would have done that, right? Net benefit, right? So I think that's net positive. Every aspect of this guy's, his A1C is normal now too. He was pre-diabetic. Everything, and he's going to need, we're going to have to refer him probably for the surgery for the paniculectomy. He's got like 50 pounds of skin on him now. But that, you know, some people that will shrink back, others don't. The guy, so see that little blue arrow there? This guy saw me back in April. Doc, I am struggling. I'm low carbing, I'm doing everything I can, and I'm stuck. Same conversation. He got started on low dose, compounded. He's like hiking with his kids now, pain-free. So, I mean, this is real, right? So, yeah, so here's, this is one of my veterans that I saw at my prior clinic. So he came over when I went to the VA. So when I first met him, he was like 360 on 10 meds, like Roxana's story, A1C 10. He's a strength trainer. And, you know, we got him on one of the earlier gen. I think he's on liraglutide. He's stayed on liraglutide. And he's still doing well. Yeah, he's still doing well. But he talks about the food noise and the stress. Like he just ate with stress. And he said somehow this medication, like it helped him deal with that. And these folks I've given permission to share these stories, by the way. So Christina and I both saw this veteran at our old clinic. He came over to the VA. So Christina first met him. He was 80 pounds heavier than he is today, A1C 10, using like 100 units of insulin, is on Trulicity, got on low carb, and that was like the secret sauce, like the combination of those two things, low carb. And again, like we're not going to pull that med away from him. He says somehow that he doesn't know what it is, but it does something to him, right? So recovery, this is the mental health side. Right, so you can read this later, but this is a guy who was on opiates. So you see there over the last few months, he's finally dropping weight. But more fascinating, he's lowering his Suboxone dose on his own. But that last sentence there, I think, is good. Yesterday I went to Denny's and wanted something sweet, so I ordered the stuffed French toast. I only wanted to try it, but in the past, if I had ordered something, I would have eaten the whole thing. Even feeling full long before finishing it, I only ended up having 2 to 3 bites and setting it aside without a second thought. You're like, what the F, right? Addiction, right? Like he somehow, and he's not on a high dose. He's not on a high dose. Again, we're talking, no, not crank the dose, right? And this is another veteran. He's off 100 units nearly of insulin. A1C better, 40 pounds off, and he works in the field of addiction at the VA. And when you get the slides, just read his whole, so these guys, like, some of the addiction counselors, like if you ask them a question, 4 days later, they'll come back with like a treatise. But what he wrote here was like amazing in his reflection of how he got to where he is now. So just, we learn, everything we learn from our patients. 3 ways these drugs can be magic. Everyone needs to read this book, The Magic Pill, Johann Hari. It's just a good read about this whole topic. He said 3 ways these drugs, he called it the magic pill because of this. Yes, it truly can be magic, right? This is the cure for obesity. This is the end of obesity. It's magic. Okay, magic 2. This is the other way it could be magic. It's kind of like your guy's doing a little card trick over here and he pickpockets you. So there's a trick. It's like a magic trick. And the third way is kind of when he talks about it, listening to him on podcast, he says this. It's probably going to be more like this. It's like, you have the little Aladdin lamp. It's the genie, right? And the genie comes out of the bottle because you want something. But what it actually is not what you want. So he's a brilliant writer, so I don't want to give him full credit for those thoughts, but I thought he's a brilliant writer. So in summary, I came here to bury GLP-1, not to praise it, or I came here not to bury GLP-1, but to praise it. Maybe both. How did that go? This is the original Caesar quote. I came here to bury Caesar, not to praise him. To praise Caesar, not to bury him. Okay, someone look that one up. All right, here's just a few things. Podcast, book. Best way to search this is type in your whatever it is, and PubMed. Yeah, you have to put the end scholar and PubMed so you don't get, someone's blog, right? So if you're searching something for real data, type in scholar or PubMed, and you'll get articles, not crap. But then, I want you to learn how to sift through the crap. Okay, so simplicity will set you through. I did okay. I finished right in an hour.
Yeah.
Yes.
It was awesome.
All right. We're not going to take questions. Everyone stand up a minute because you've been sitting far too long.
There's one person I have to let ask a question.
Oh, okay.
Sorry.
But we can at 12:30 just hang out. I'll come up here if people have questions on this. I'll go through the lunch hour.
Remember, I'm an ish person, so.
Yes, okay,
ish.
we're ishy, but we can't go too far off ish because then we really screw the day up. Oh no, Ken has a question. Keto harder.
Thank you for this presentation. I think this is something that needs to be talked about.
Yeah, we'll talk about
I
it.
want everybody to keep in mind that as a physician, we may have beliefs and we may have kind of blanket paradigm thoughts about things, but when we're in a room with a patient, we do what's best for that one person at that time in their patient career.
Amen, brother. Yeah.
And so I've heard some rumblings in the back about, why aren't we talking about this? Well, because doctors have to do what's best for their patient. And sometimes that doesn't toe the party line, but it's what's best for that patient. And so thanks for this presentation. I think it's something that needs to be talked about. And I think that the GLP-1s have a useful place in medicine when used judiciously and when all the patient is always given informed consent. And that's a very loaded term. Informed means here's the good things this could do for you, but also here's the bad things. And I'll bet you that Dr. Cucuzzella says to every patient he recommends this to, now there are also unknown unknowns
Absolutely.
that you may suffer from in the future.
Yes.
And we don't know, because we don't know. So thanks for being brave enough to talk about this.
Well, just before we go to Amy, yeah, so if you're wondering why I chose this topic, you know, the theme is never give up. So I see people back who have tried, you know, post-gastric bypass. They're regaining weight. Are we going to give up? Like, you know, Ken or I as clinicians? No. So we need to have, you know, we can't all just be one-trick ponies. We have to figure, so we're never going to give up on people. We're never going to give up on people. And this might be a tool for someone who is struggling. You know, that's all I want to say and about this. And if you're going to do it right. We've gone all wrong in the last 2 years once this became an obesity drug and people started cranking the doses. And I mean, that's like, we just went sideways. Forgot everything that we learned about these meds when used appropriately.